interactive discussion on the upcoming EDIC 2 exam. So, welcome friends. We all know that somehow we are all trying to get the coveted EDIC diploma, which is one of the most prestigious diploma currently worldwide. And from India, many of the students in last, you can say 8 to 10 years have cleared it. And after this 2015 January, if anybody has cleared EDIC 1 and EDIC 2, so definitely he is directly eligible to get GMC registration and they can work in UK and NHS. So that is one of the added advantage. And in most of the countries nearby also, the neighboring countries to India, they have right now accepted EDIC as one of the one of the respected degree apart from the Indian DM, DRNB, IDCCM, IFCCM, and many of the other degrees. So to start with, you all are brilliant. We all know because you have cleared EDIC 1. I hope everybody who is today in this meeting, they are trying to get the EDIC 2 and they have cleared EDIC 1. Now, they are definitely brilliant because they have cleared the EDIC 1 with flying colors very successfully and with distinction. And many of the students from the previous the batch for the EDIC 1, which is named as Tricks 1, which is for dedicated for only EDIC 1. So they have also cleared, and many of the students are here also today in our introductory class. They have also already registered for the EDIC 2. So Dr. One of the Marudwar is one of the the successful candidate for the EDIC 1. Now, let's come to the EDIC 2, which is today's discussion part. That I would equate with the World Cup. We recently concluded the World Cup and everybody is right now aspiring for the EDIC 2, which is almost equivalent to World Cup because I am a fan of soccer. So I would definitely put many examples with the World Cup. Now, when we started the World Cup campaigning, all those the matches, before the pre-match discussions. So we from different teams, everybody was aspiring for the World Cup. But finally, at the last day, you could see there are certain the teams who have qualified for the quarterfinal, semi-final, and then final. Despite the people, the players, they have given their best effort. It's not that they have not tried their best because it comes in 4 years. So you can imagine the level of commitment and the expectations and the emotions that is involved in the World Cup. Now, I would equate this to EDIC 2. You are all trying to get this EDIC 2. It's not easy, I would say, without proper preparation, but definitely it's worth trying and worth getting. So are you all ready to start the journey? Because we have already cleared EDIC 1. We have already finished some of our fellowships, some of our diplomas, some of our training in India, abroad. So now we are trying to get EDIC 2. So there are certain well-proven points I would try to first start with, because that would clear our doubts why the EDIC 2 preparation is not so easy, or why we have tried to start with this type of preparatory course 1.5 years back, because this is our third season. We are starting and we are continuing with the EDIC 2 preparatory course, which is named as Tricks 2. Critical care medicine, we all know, is right now not a subspecialty, rather a super specialty, and is ever evolving. It needs focus, strategy, and practice for any of the exams related to critical care. EDIC exams is very much structured, comprehensive, and they need proper planning to appear as well as pass. The preparation needs to be guided and start early for success. It cannot be overnight. You will just spend 15 days, 30 days, and you would clear it. It is really difficult. Yes, there are exceptions. There are certain intelligent people who can clear it. It's not proven that you would require 6 months or 12 months like that. But yes, early, the better. Now, the problem what we normally feel in India, because we started like I have cleared my edict to almost 7 to 8 years back, and we felt that in India we do not have a structured course format, or the heterogeneous academics unplanned, and we normally devote our time for most of the time in clinical work, and we do not know what to read and what not to read. I would say what not to read is also very important. We sometimes try to grasp everything what is there, but rather focus on a structured pattern, a course or a preparatory strategy that would give yield more knowledge rather than only like the voluminous books we would be completing at the end of 2 months or 3 months. We try to in the respective hospitals, again with due regards to all those corporate hospitals or different hospitals where the diploma, the degree courses are going on. We normally try to focus more on the clinical management rather than the academics. No one anymore in our hospitals, in our colleges, holds hand to teach and makes you learn and smarter professionally, because everybody is right now busy treating the patients rather than the previous MBBS time. We can imagine at that time there were teachers who were holding hands to learn ABC of medicine, ABC of surgery, whatever may be. Now we are not right now getting enough time also. That is one of the mega, you can say, the problem we normally get from the candidates, that we do not have time. We have all the other works, we have the clinical work, we have some time for family. Now we are not getting enough time to study like our MBBS or MD days, where we just devote time in the library or at our home, reading the books, preparing the previous year's questions. Right now it's not so easy. Yes, the obvious reasons are there. It's not that nobody wants to read, but yes, it's very difficult. Now we are also graying of our gray and white matter in the brain along with the hair. So we are aging. That simply we can say we are aging. We are not at 25-year guy and girls that we can only devote for study. And definitely we are right now have major concern for our family and our personal time also. So for that reason, we thought of starting courses under 360 critical care, and we are here to help you. And this is not only didactic lectures from our side, but yes, we are here to advise. We are here to give you tips. We are ready to assist. We are ever ready to help you and support and guide in case you need anything from the education point of view or your EDIC 2 preparation. There are certain points before any presentation is prepared. Disclaimers. This is not an official presentation from ESICM. We need to remember the views what we are trying to present here is based on our experiences over years of our teaching and training, as well as our own practice. And this is also derived from our own experience and the problems what we faced during our preparation for the exams, and also teaching over years. The candidate who are preparing or who is planning to prepare for the exams, they are free to follow his or own path, brain or heart. It's just one guidance, and we are here trying to consolidate all the important the structures, the study materials, so that you will be feeling easy to prepare in your busy schedules. And the webinar currently we are having is being conducted to give overview of candidates who intend to write the EDIC 1 as well as EDIC 2 in a better systematic way to clear them. And this domain, this discussion is only for EDIC part 2. So before that, we all know EDIC exam, if somebody is trying to clear EDIC 1 and EDIC 2, but trying to get all this introductory knowledge about EDIC. So it is a two-part exam. Part 1 is the written, part 2 is the oral or clinical case exam. Twice conducted, spring and autumn session. And definitely it is one of the exam which is meticulously developed. Continuously they try to update it to create standard exit exam, which accurately reflect. There are certain things. It's not only the knowledge which they are trying to guess by giving one or two, you can say 2-hour exam, and they can just clearly guess. It is scientifically developed because I was the ESICM Asia Pacific representative for 3 years. So I know in their meetings how they discuss about updating the exam standard every year. So they try to address the necessary skills, the attitude of the candidates, the competency and knowledge required for a safe and reliable intensivist in your respective ICUs. So that's the final goal, if I will say, for this EDIC exam preparatory course. We all know EDIC acceptance is right now in most of the countries in Europe. And there are like countries like UK, which accepts this EDIC part 1 and part 2. If you are clearing, then you can directly go and practice there as a specialist. So without further wasting time, I know we all know how to start preparing or thinking about EDIC. You have to visit their site. It is esicm.org, create an account. You have to start filling up the EDIC profile, which is a prerequisite. Why I'm trying to say it? Because on 9th, they are again opening one special link for the candidates who could not get a seat last time. And on 16th, that will be a general common, you can say the link will be open for the candidates who are planning to appear this exam in this upcoming season. So that's why you have to be ready with your EDIC profile. It's not easy. It takes hardly 10 minutes time, but it has to be prepared before. Otherwise, on the day of opening the link, and their site actually gets so much messy on that day, you would be really finding it difficulty if you have not prepared or kept all those things handy. Otherwise, you will lose the important time and the seats will be filled up. So that's very clear. And one of the example is Dr. B. Mohan, who was tried last time. He is about to clear. I can how for that, but somehow he could not get the seat because the seats it just gets filled up within I think 1 to 2 hours. I recommend you to become a member of the ESICM, which is renewed annually, though it's a little bit hefty amount, but yes, we need to do that. Otherwise, what is happening? Because you can directly go for the registration of the EDIC 2. But yes, if you become a member, there are certain advantages. Like you will get access to the S modules, which was previously named as packed modules. And there are many events conducted by ESICM. They normally store all these recorded the meetings so that you can go through all those things also in your leisure time. Very informative, and most of the world authorities in the respective fields they present, and that is really useful if you have time to get your concepts clear. Definitely, if you become a member, you get the EDIC exam discount. And also, if you plan to visit the SISM conference also next year, so definitely you will get the discount for the EDIC conference registration also. And this is the website details. You can visit that and know the benefits of becoming the member in a greater extent. So if you are planning or applying for the EDIC part 2 for the upcoming season on May end 2023. So it is, I think, on May 26, 27 or 27, 28. So I'm not sure, just forgetting 1 or 2 days. But yes, it's toward the end of May. And the first link will be opening on 9th. And the 16th would be the common link for everybody to try their luck. So it's January 8, 7 is today. And your exam is, if it is May 27, so it's hardly 4 months. So pull up your socks. It's not good enough right now to go through all those books and start preparing from A. It has to be really structured. Otherwise, you will lose your time, and somehow you will be towards the end of the your 2 months, 3 months, you would be really stressed. So EDIC part 2. So my part would be, along with me, I welcome Dr. Manjunath, who is consultant intensivist at Manipal Hospital, Bangalore. So he would be discussing about some of the important domains. Normally the candidates tend to forget. So that would be the second lecture. And I would be discussing about the everything and anything what you want to know about the part 2 exam, the formats, the books, the resource materials, how you should start preparing. So I would be taking that almost like 15-20 minutes more to give you one like you can say broad idea about how to start preparing. So the format for part 2 exam, because there are many students or delegates, they are planning to appear, though it may be this season, upcoming season, or maybe in the November season. So for that reason, I want to give you one broad idea. What is this part 2 exam? What is the format of this, the part 2 exam? So part 2 exams are different from part 1, being oral and clinical based exam. So there is no MCQs, no detailed like the knowledge length and breadth of like you can say the percentage of cases, the landmark article should be asking about the detail analysis. No, it's oral and clinical, very clear. The part 2 exam is following the model of OSCE, that is objective structured clinical examination, and there is a blueprint derived from the competencies listed in the sorry Covertris test syllabus. So this you can go through, and on this Covertris system there are like different domains. Why I am telling that? You have to understand their like score structure or the exam pattern, the domains from which the question should come. Otherwise, if you start like reading a textbook, what we normally follow, like Irwin Ripe or like this new John Louis Vincent, all those like textbooks, you may fail or you will not get a typical like representation of what you are actually being asked. So it's a European exam. So definitely the European system, the European structure of questions, they are like own theory part, they would definitely refer to. So that's why you have to go to this link, yesism.org, education, Covertris, to get a detailed idea what is the actually the exam is all about. And the exam guidelines and regulations, though it's saying 2018, but you have to be sure about the current year in which you are actually applying or appearing the exam. The candidates normally they have to go through 3 to 4 clinical case scenarios, that is named as CCS, and 3 computer-based stations, that is CBS, which includes biochemistry, image, curves, and graphs. So very clear. 3 to 4 CCS, sometimes they change it to 2, sometimes to 4, but yes, you need to be prepared with CCS. Sometimes they like give you one long type, then like 2 short type, something like that, but its broad idea is CCS and CBS, and CBS is all about the what we normally say in our Indian exams, the table viva, the biochemistry, image, curves, and graphs. You have to compulsorily pass individual CCS and CBS sections to clear the exam. Now, they for last 2 to 3 years, they are actually calculating the total CCS you have to clear. Then so total CBS you have to clear. Though you may be failed in 1 or 2, like the CBS stations or CCS stations, but if your total marks is actually above the passing mark, so you can pass. So that is again some changes they have done in last 2 to 3 years. So coming to the CCS, what is about this like CCS? These are the real cases managed in European ICUs. Very clear. They would not put some fake cases. And I am observing their exam for last, I think, 4 to 5 years. So I know. So the ventilatory graphics, the CBP waveform, the TAG report, the ABG report, what they normally put in the CBS, that is actually from one European ICU and real case. Then the CCS, the clinical case scenario, again, that is very like appropriate for the European ICUs. Like in the winter season, they would definitely give you something related to hypothermia, severe hypothermia case, because it's all like the countries they are having temperature of around 2 degree, 3 degree, 5 degrees. So they would definitely sometimes put one clinical scenario related to hypothermia. So that is representing their own clinical cases. So in the online format of the exam, which has been started since the COVID days and it's still ongoing. So we do not know when they will change it to on-site, because I have appeared the exam on-site. I guess Dr. Manjunath has also appeared in the same format on-site. But yes, for last 2 years or 2.5 years, it is online. So before the CCS, the exam starts, you will be given one clinical vignette, 25 to 30 minutes in advance. Again, last time they have given only 5 minutes before. So these time durations, they can change. Again, for that reason, we normally do not recommend all these like not minutes, like 25, 30 minutes. It cannot be like mandatory. Like what we are saying, they may change this time also. So that would be normally by the ESICM EDIC secretariat. They normally send all those information 1 week before or 10 days before the real exam. And they sometimes like go for one tutorial also 2 days before, 3 days before the real exam. So I request everybody who are like applying or like appearing the EDIC to this season. So you have to go through all those important tutorials given by or shared by the EDIC secretariat. You have to definitely when the clinical vignette will be given to you, you have to go through it, and all the questions that would follow, that would be based on that clinical vignette. Then once you clear that the first vignette will be given to you, but the following vignettes, that would be instant. Once you go through all those questions they would ask, then the second clinical vignette, the third clinical vignette, the fourth clinical vignette, that would be they would share on the screen there itself. So you won't get it beforehand, rather you have to read it on the screen, and they would ask you the questions following that. So very clear. And normally this is CCS, one CCS that stands that lasts for almost 25 minutes. So be prepared for that. If it is 3 clinical cases CCS, it would be covering 25, 25, 25. So if it is 2, 25 plus 25. But yes, the time will be also vary. Why? If you are unable to answer most of the question, so definitely they are forced to proceed on the second clinical vignette, the third clinical vignette. So definitely it may vary from person to person. It cannot be again. Now, so answers to the clinical vignettes that carry 1 point each. Before 3 to 4 years, it was having 5-pointer, 3-pointer, 1-pointer. When I was appearing the exam, I have given the 5 point, 2, 3 point, and 1 point, depending upon the most important answers and the less clinical relevant answers. But now it's all uniform. If you answer, there are 5 answers to the question. So if you answer 3 correctly, it will be 3 by 5. If you answer 1, it is 1 by 5. If you answer all 5 correct, it is 5 by 5. And finally, the calculation will be including how from the total marks, if it is 45 or the marks would be, you can say if it is 150 marks, so how many points you have cleared successfully. So it would be 100 out of 150, something like that. So the more you answer, the more marks you get. But it's not that you will be only talking and you will be dragging the the questions to n number of answers. No, it has to be very structured. The disadvantage of giving more answers without relevance to the question, you would be losing your time, and definitely that the examiner would not get enough time to reach to the last question, because the time limit is fixed. So if you think that I am, sometimes the candidates, they find it very convenient that yes, I would be only describing n number of answers to the question. This can be happening, this can also happen, this can happen. If you can tell 10 DD rather than the 5 DD, so you are actually losing the time. And also that would be confusing to the examiner that you are actually knowing it, or you are only guessing blindly with all those possible in the clinical vignette. So for that reason only, you have to follow structured course, the practice tests, mock tests, preparatory course. Otherwise, what will happen? You feel that you are answering correctly, but it is not actually hitting the bullseye. So that's very clear, and that has to be kept in mind. Usually, if it is 3 clinical case scenarios, one would be starting with or revolving around surgical, one would be medical, and one from some subspecialty like neuro, cardiac, endocrinology, trauma, something like that. So, but it's not again hard and fast, but yes, it would be one would be normally post-surgical complication and leading up to some of the other complications normally we encounter in our ICU. The first one or second one would be medical case like diabetic ketoacidosis leading to like organ failure, finally leading up to like ECMO, and finally end of life like care and communication part. And one would be something related to neurocritical care, cardiac critical care, something like that. Now, the CCS, if we would be dissecting further, in the 25 to 30 minutes time you get for the preparation before the case starts, I would advise you like to think about the question spectrum, the extent of like, the questions they can reach up to. So I would give you one imaginary like idea or like, something related to that, that if somebody is like asking or starting with a community acquired pneumonia and the patient is right now deteriorating. So in the next clinical vignette, you would expect that this patient would develop AKI. In the next like after 2 lines, they would be putting the clinical scenario of CRRT. And after like 2-3 questions, that would end up with cardiac arrest. And then there would be like the neurologic prognostication, and finally the end of life care and communication. So you have to think about that the questions can like start with pneumonia, but you to end up with like end of life care. It's not that it's a respiratory case, so I would be like telling about the scores. I would be telling about all those like guidelines, the BAB, the culture organisms, the antibiotic. No, they would not only restrict you to one system. That's very clear. And I want to give you very clear idea that your reflexes has to be very sharp. So you would not expect that a cardiac case ending up with neurologic. So I hope everybody is clear on that. Now, whenever a question a CCA starts with, you have to start with, they will ask you some like clinical vignette that would be starting with, and they would straightforward ask you, summarize the case or what is the probable diagnosis. So there are normally 4 to 5 answers for each question. Clear, make it clear. So any question would be having almost 4 to 5 answers for each question that are worth points. So be brief and to the point. They do not want to listen from you very lengthy answers. Just normally we normally expect from our DM or our DRNB students or IDCCM or IFCCM students in our critical care practice. So it has to be very structured answers. How you frame it, again, that depends upon your preparation. Sometimes you are right on your way, but definitely the examiner do not want to listen to like a long statement like what you are normally telling in the our real like in our clinical rounds or something like that. They most likely want to hear about the organ dysfunction, and history is almost always not important to mention for this question. You should not repeat again the question, or like 24-year-old male presented with a road traffic accident, now ending up with like multi-organ failure. No, it's all structured 1 point or a 1-line short answers, and that would give you more marks. They may ask also, what is your differential? What is your immediate management? It's ICU, it's not medicine, it's not surgery. So be clear that in ICU normally the attending is expected to know DD. On the basis of DD, you will be starting your management. Again, your management has to be immediate, and then the like the normal like how we do it on everyday basis. The immediate management would normally involve with ABCD approach. So always I advise you to go with a structured approach rather than very like haphazard answer. You will start with I will maintain the airway, then immediately go to the focus, immediately then go say that I will give fluid resuscitation, then I would do the monitoring part. No, it has to be a structured, and it has to be there has to be the examiner would get the idea that yes, the doctor who the attending who is answering right now at the bedside is making sense of what he is actually telling, and he should be confident that yes, at the end you would be either you save the patient or you can convince the family relatives that yes, we tried our best, but somehow we could not save because of the rapidity or the progression of the disease so fast. So the question can again go towards that for the further investigations. what can be the cause of the patient's hypotension, fever, pain, abdomen. So it's all like no problem oriented questions rather than theoretical questions. So that's very clear. Now, maybe I have already told that the case would evolve further. Every time you would get one clinical vignette, you would expect that the next clinical vignette would be having something different. And don't be surprised, I have already mentioned this, if a cardiothoracic case evolves to a neurosurgical one. And you will be definitely given new investigation results in each clinical vignette, CT scans, X-rays to interpret. So it's not only the CBS, the computer-based stations, that would be dealing with all those double viva. In the clinical case scenarios also, you would be getting some CT scans, X-rays, and the next clinical vignette or question setup would be depending upon the CT scan finding or X-ray finding, what they are showing to you. So the further the questions that can also relate to the physiology, questions regarding the evidence, if there are certain landmark articles in that clinical vignette or the clinical scenario they are highlighting. So definitely they would be quoting some like landmark article there itself. Do not be alarmed. Only the actual trial names and the conclusion. So in the European exam, they do not expect you to like critically appraise the landmark article there with all those like statistical analysis, everything. It's only clinical exam. So be clear in that. Explain how we do it, and maybe some physiology related to your way of practice. There may be questions regarding counseling the relatives. Yes, in European exam, in any Western exam, they expect that you are thorough how to communicate to the family. And if you have done something wrong or there are some negligence that has happened in your ICU, maybe by you, by your nurses, how you would handle if an error has occurred. So that also is one of the prerogative of our critical care practice, the counseling part. So there will be definitely questions or the discussion on the end of life care, brain death determination, and organ donation. So now most of the clinical case scenarios ending up with organ donation, because right now it's the awareness is increasing in European countries as well. Now let's come to the computer-based stations. There are 3 stations I have already mentioned. CBS 1 would cover the ECG and other curves and graphs. CBS 2 would cover the radiology, and CBS 3 ABG and biochemistry. So this is one rough division of the 3 CBS. So you have approximately 10 to 12 minutes for each you can say station, computer-based station, and there would be 8 to 12 cases they can keep in that. These stations, and everybody who has cleared the part 2, they can also be part of this statement that this is probably the most difficult one. I would say last time when our tricks to the batch, they appeared the real exam, that day evening everybody was shattered. I would literally use the word shattered by the performance, because they were not expecting that the question routes go like this, all bouncers. But it's not that they could not answer it well, but the exam the 10 to 12 minutes would be so much stressful that you are not sure whether you have clearly mentioned the answer correctly or you have done something wrong. But happy news for everybody that out of 45 candidates who were there in our last tricks 2 batch, Dr. Bimohan know them also. So 38 candidates cleared, and that day when the result came, I just told that yes, the exam time would be so much stressful, and again it's online. So there are problems with the internet connections, the system would be hanging, and there are many things that also affect your exam. So it's not only the knowledge that counts, but yes, how you confidently answer, your accent, your understanding of the question. So these are many things that has to be developed gradually. So it's not that you know the theory part and you answered it well, that means you will pass. No. So there are these things are very important to understand. Actually, this is not written in any of the books. This is all from our own experience and knowing about their their style of conducting the exam, and also the candidates feedback. So the most important problem with CBS, it is the time limit is there. If 12 minutes is over, so if you are with like eighth number question, maybe you would be missing the next 4 questions, and that would make all the difference. So those 4 questions would be very easy, and you have actually not seen those questions because of the limitation in the time. And again, how to prepare and how to answer it quickly, that is also tricky. So that's the reason why CBS to be given more importance, I would say, from my personal experience. Both are having their own importance. Now, all cases in the CBS as well, they come with a brief clinical information, clinical vignette. This is very important. Many times the clue is in there rather than on the image itself. Like you can see one line, one formula, or some information that would lead you to the answer rather than going through the long question, one page, the details is not needed. So read the clinical vignette first, and usually there are questions regarding the management. It's related to management. It's not related to the physiology or related to the pathophysiology, something like that. They would not expect you to answer these in the CBS. Rather, it's only related to the management, the complications, the troubleshooting, something like that. Again, you barely have more than 1 minute per one question, clinical vignette. So that's the reason why CBS, you need to be very thorough in your preparation. Coming to the curves and graphs, I'm just giving you a broad idea. Dr. Manjunath would be discussing about some of the important domains. But yes, it's a vast topic. If I would start now, what are the important things that can be asked? It would take 3 hours, 4 hours. So it won't be possible to detailed give the discussion. Rather, I would be only giving you the highlights of the upcoming the CBS. And believe me, I don't know. I have given one day before in our the last batch about posterior infarction, posterior MI. That yes, this can be a question. Believe me, maybe the candidates immediately on the day of exam in the evening, they told that there was a question on the posterior wall MI. So I don't know, but yes, sometimes the guesswork works. And the ECG, normally that would be based upon the MI, heart blocks, drug toxicity, electrolyte disorders, pacemakers, some malfunctioning pacemakers, arrhythmias, and their management. In the ventilator graphics, they would expect the trainee to answer or know about auto PEEP, trigger or cycling asynchronous, peak or plateau pressure problems. CBBO curves, it would be tamponade, regurgitation, stenosis. IABP is one of the favorite question in any of the critical care exam, and European exam also. It would be definitely they will ask you 1 or 2 questions, maybe in the CCS or CBS. And part 1 also, normally they are asking 3 to 4 questions in the MCQs right now. So the troubleshooting, the early, the late inflation, deflation, the problem, what is the problem, how will you correct it? So this would be definitely be asked. ICP, the waves, the ICP monitoring, the cerebral autoregulation, that can be asked because they expect that this candidate has worked in the neurocritical or neuro ICU. Then simple CRRT pressure trends. This is again very common right now. They are asking troubleshooting for the pressure changes. ECMO, troubleshooting for the pressure changes and oxygenation. The biggest problem is that there is not a lot of resource online for the vent CBP or ICP curves. So what you normally I would suggest, do your Google and try to practice at work and try to take help from your colleagues. Make your own, you can say the encyclopedia, and write down the CBP, then ECG, then ABG, and try to keep all those important troubleshooting, so that at the end you cannot depend upon 1 day, 2 day preparation. It has to be a structured preparation for almost 3 to 4 months. Coming to the radiology imaging, the list below is not extensive. They say all cases are emergencies which you should be able to recognize before official radiological opinion. Normally in our practice, we immediately refer to the radiology, but when they ask you the question in the exam, they expect that how to distinguish between which is emergency, which is not emergency, and what you are dealing with. So that is very clear. CT head, all types of like CT head, ischemic stroke, bleed, TBI, intracranial hypertension, hydrocephalus, different CT angiograms, CT abdomen. It can be free fluid, intestinal obstruction, pancreatitis, pyelonephritis, solid organ trauma, aneurysm, bleed, CT chest. That can again cover whatever chest wall injury, pneumomediastinum, pneumothorax, rib fracture, lines and tube in the CT chest, aspiration, aneurysm, contusion, chest X-ray. We all know some atypical chest X-ray, IBP tip, then the lead fracture, the pacemaker lead fracture. That can be also asked to you. Abdominal X-ray, IBC filter tips, some atypical in the abdominal X-ray. Hollow viscous perforation, large bowel obstruction. Ultrasound, again, we expect everybody knows about the POCUS. Some like abdominal ultrasound also, like hydronephrosis, some pyelonephritis in the ultrasound. Echo, they expect now to know about not only the fluid responsiveness or the simple like the POCUS for the cardiac focused echo, rather little bit detailed about the pulmonary embolism, the diastolic dysfunction, and the Takotsubo-cardiomyopathy, cardiac tamponade. So all these things you need to know. Quite a range of topics to be covered, but I don't know like how you should prepare. But yes, definitely look at images from the different websites. There are certain useful websites currently available. Radiopedia.org is one of that. You will find a plenty of images, but you need to make it concise what is required for your ICU practice. And you can also discuss with your colleague at work or radiologist friend. Now, coming to the radiology images, I have already discussed this one. This is just repeat. Now, so you start preparing from where you left for the part 1 exam. So certain clues or clinical pearls. You need to start preparing for at least 6 months, but minimum 3 to 4 months you need to keep for this EDIC part 2. And that's why we start our course 4 months before only. And basic knowledge of critical care can be acquired by reading a standard critical care textbook mentioned in the later slide. I will be showing you the the standard textbooks. Part 2 exam will test your knowledge and ability to become a consultant who can take independent decisions on the management of critical ill patients. So it's not that you will be again getting a plea that yes, I will ask my, or I will request my senior to opine about my case. No, they expect that you take immediate quick decisions at the bedside, what to go for or how to proceed. So there are certain clues. I would be not taking much time, but yes, how you manage a case when a patient comes to your the emergency bay, sick patient is strolling into the casualty, and how you should proceed, managing the ABC, followed by some investigation, some focus, some bedside point of care investigation, certain procedures, certain immediate medications, shift to the ICU, then how you manage it overnight, then next day when you come to the ICU, what are the problems in hand, how you should address those issues. So that is the normal format, how you should start preparing your CCS. And for the CBS, I have already told, whatever is right now from today or from tomorrow onwards coming to your hand in your ICUs in the respective hospitals, start keeping that in mind that this can be asked in my the EDIC part 2 exam, real exam. Then you would make it in quick time about the problem solving the points, HME filter, capnograph, ECMO, pacemaker, whatever is right now visible in your ICU, you think that this can be a question, then you will get that kick to keep it in your the diary, and that would be helpful in the clarifying your concepts. You can go through these PACT or S modules, but yes, it is, if you have not prepared till now, definitely it would be taking much time. So I don't recommend that you have to again go through this, because I expect that for the part 1 you have read at least something from this S modules. Yes, ICM website, definitely you have to go through certain webinars, recent webinars. be updated with all those landmark trials and all the recent publications. Maybe whatever you are actually quoting in the real exam about the CCS answers, it would be evidence based, and you must be thorough about all those recent advances. Prepare your notes, maybe handwritten or in your iPads, tabs during your exam preparation, which will help you during your last minute revision, because that is very important. For last 10 days, 15 days before the real exam, you would be totally confused, you will be stressed. So maybe you can go through all those important notes what you have prepared in the upcoming the 3 months or 3.5 months. So that would definitely help you, and you would not be confused at that time. So that is our all practical experience. And these are the test books. Normally the European Society, they recommend, but yes, it's not given in their website. So OAS intensive care manual is from the UK. So definitely it's a European exam. So normally, preferably, if you ask some of the seasoned examiners, they would quote this one. Then this is the most recent one, 8th edition by the Vincent. It's a very good textbook. Again, the most important point is it is the most recent one. This is published just 1 month back. And Irun Ripe, if you have studied in your training time or in your EDIC part 1 time, definitely you should refer to the these textbooks. Otherwise, I would not right now advise you to go through all these textbooks. It would take much time, and in the EDIC part 2, it is all structured questions. So it won't expect you to write down 3 pages or something like that. Normally we expect in the DM or DRNB or IDCCN exam. So these are the textbooks. You can choose one. And these are the few internet critical care resources which can help you to enrich your knowledge. Life in the First Lane, MCRIT project, deranged physiology, up to date, ICU one pager. So if you are are well versed with the all these websites, you can immediately refer to and get the ideas in maybe 5 minutes, 10 minutes. Reading resources for part 2. This is one Australian book, Examination Intensive Care Medicine 2nd edition. Data interpretation by Dr. V. Venkatesh. OSCE for the final FFICM. OSCE for intensive care medicine. ECG for the emergency physician. ECG for the emergency physician. There are different books. Cases in clinical or chemical pathology, diagnostic approach. Then this is again another book by Australian board, Objective Structured Clinical Examination. So these are the rough idea how to start preparing and go with all those next upcoming 3 months. I would not take much time more because already it's 7:53. So we plan to come up, and we have right now displayed our the way how we will go ahead. So these are the few dates very important for you. 7/1 is today, which our this free introductory class. Then 9th would be the ESICM link opens for the registration for few selected candidates. Already they have got the the emails. And 16th would be the common the students, the ESICM usual website link. Now on 18th we would be again having one other the free introductory class where we would be discussing about certain points about communication and end of life care, which we are not very sure in our Indian context, but we would be discussing from the European perspective, because the exam would be the European perspective. And from 10th February, we are starting the tricks part 2, which is the dedicated preparatory course for EDIC part 2. So from 10th February till May last week. So there are almost 30 faculties who are EDIC qualified in our this course, and it is highly acclaimed. This is the 3rd season. I would bet you it's almost 85 to 90% people they have cleared, and it is all chapter wise coverage. Then there would be access to the tricks cloud, and also you can access multiple times the masterclass videos, which would be every week on Sunday. So with that, I hope everybody this year would be holding this European Diploma in Intensive Care Medicine for the certificate in your hand, and they can post it in their social medias. And we hope that we can be part of your success, guiding you, assisting you, or maybe helping you in your preparation. And if you have any questions, I would be happy to help you. Good luck for your exam. And I would like quote this and end my presentation. I have not failed. I have just found 10,000 things that do not work. So maybe with that attitude, we should start preparing. But I expect that nobody would quote this first line. We'd all say we have passed or cleared. Thank you. Thank you, all of you. Yeah. So, yeah. So, Dr. Manjunath,
Yeah.
please share your screen. If you have any queries, you can post in the chat box. At the end, both Dr. Manjunath and myself would be clarifying.
Yeah. Hello. Hi. Yeah, I'm Dr. Manjunath. So I work as an intensive care consultant at the Manipal and Whitefield and Bangalore. So I think Dr. Tapas has told and most of the things. So he has covered almost around 60 to 70% of the things. I will take you through the most important and the topics and how your approach should be for the next 3 to 4 months, like for your exam. So see, and we all know. So see, if at all, if you have to sit and study on your own, the 10% of under what you read, in the sense, if at all, if you have read 2 to 3 chapters in that and you remember only under 10%. And what we hear, it is only 20% and we remember. And what we see, it is only 30%. And all this is on evidence based. And what we hear and see, it's only 50%. And what we say, it's around 70%. And what we say and do the daily in your like practice, it's around the 90%. It's rule of under 90. So what I recommend and all of you is in your and the daily ICU rounds, in your daily practice in your intensive care units, the whatever the patients you see, please consider that like patient as an exam case scenario and go ahead, see from the airway breathing circulation, approach the ABGs, the CT scans, X-rays, your approach for the next 3 months, if it is in that way, so then this exam will be like a cakewalk like for you guys. If at all, if you think no, I'll sit and study with all the books, yeah, it is agreed, it's not, it will only help you around 20 to 30% to get some basic funda for that concept or for that under topic. But your approach should be on the bedside, discuss with your the colleagues and the seniors, and it will actually show you the benefit at the end of the exam. And don't waste your time in the reading and a lot of theory, because like, we know and you have read for the EDIC like part 1 and you know like almost all the like, basic things now. So and now in this exam, as and the Tapas has already told you guys that they they will assess you that like whether you're good enough to become a consultant or not. And the second thing is, and your like plan of action is appropriate for that patient or not. And the third thing is, and you are like safe, you are doing the like practice and safely for the patient or not. These three things are like most important and for them to assess in the exam. So don't waste your time and the reading and lot of theory as like a preparation always, and do discussions like with your colleagues and the seniors, and thoughtful process like should work on the approach. And you should get that and the idea. If at all, if you get a like patient in the ICU and the new patient from the ER, if, and the shifted to intensive care unit, they see the ABG and see and what exactly is like problem like metabolic and the respiratory acidosis or any triple disorder in that, and see for the differential diagnosis. And after you do the differential the diagnosis and how to rule out with the imaging like CT scan, chest X-ray, or any other imaging and the required, and treatment and the plan. And for this exam, you cannot answer beating around the bush at all. No, be specific in your answers. If at all, if they ask you summarize the case, tell only the most important things and be specific in your answers. And as I as and Tapas has already told that and most of the things that a CBS station, the computer-based scenario, the 10 to 12 minutes, and you will get around 8 to 10 questions over there. It can be 8 to 10 or sometimes under 12 as well. If at all, if you don't know, and you can actually tell, pass the question. So no need to waste the time on the time there. And you can actually, if at all, if you have time at the end of the station, if you still have in the 2 or 3 minutes, you can come back there. And the time constants, for the time constants, the best thing is you should like practice these sessions before the exam, like under solving the ABGs, the CT scans, the MRI, and also on the chest X-rays and all the curves and the graphs. If at all, if you keep solving this and repeatedly, your thought process, it will the work in like seconds, and you will be able to answer immediately. And read the question and carefully in these understations. Don't jump to the images. Sometimes they need only the abnormality in the image, but sometimes the question will be for the and the treatment of the abnormality. So always read the question carefully and don't jump to the images, and always stick to the question. Don't tell unnecessary things and waste your time. And look at the image and the videos and the carefully. And the what we have seen in the last and the 3 to 4 years is, and they have started uploading the echo videos and the ultrasound and the lung videos. So which actually gives some kind of, it takes around 3 to 6 seconds of the like a video, and it will come up with a diagnosis. So look at the image, the videos, all this, most of the videos are available in the Google or the YouTube. If at all, if you want to see any specific under diagnosis, the echo videos, and you can see that. And for all this station like should go effectively, you should do lot of and the practice sessions with your junior or seniors. See, take the X-rays, the CT scans like pancreatitis or perforation, or like CT brain with like ISCH or any intracranial hemorrhage or any under trauma. All these under CTs, if you start doing like a practice in a the specific way, if at all, if you take like CT brain, start from the skin, subcutaneous tissue, like the bone and the like brain parenchyma, and you should go in a correct method. Sorry, yeah. So coming to the one second. Coming to the ABG, the stations, and you should know these like formulas and very well. And if at all, if you have to and remember these like a formulas, you should like practice and daily in and out at least around 5 to 10 ABGs, and you should like solve and the daily at least 2 months and before the exam. So then you will become under perfect. And there, if at all, if you know these like a formulas to attempt it in the exam, so then 50% of the ABGs are like solved, and you will get the diagnosis immediately. If at all, if you don't know these like formulas, it will be under really difficult for and the corrected and the anion gap and the gap the acidosis and PaO2, the arteriolar and the alveolar and the gradient, how to calculate the compensatory and the formulas, everything. If at all, if you know this in and out, so then your under diagnosis becomes and the easier with the diagnosis, and you can tell the treatment, and you can get the MCQ and the correct immediately. So like practice these ABGs daily in your practice. Yeah. So in ABGC, we know that there are compensation and osmolality like formulas, all that. So their ABGs are entirely different. So it comes up with the triple disorders. The patient can have the metabolic acidosis and alkalosis and the respiratory acidosis as well. So these triple disorders, until and unless if you don't recognize that in the exam, your diagnosis, it won't be the correct. Always look for the triple disorders in all the ABG scenarios. Think, and whatever you get, it has a triple disorder. I've seen, if at all, if you get a disorder correctly, then your diagnosis will be 100% and the correct. For this triple disorder, for you to be perfect, and you should do the practice again and again and again, and the calculations and whatever you do, it should not consume time. So because, and you have only around 1 to 2 minutes, it's not even under 2 minutes. It's around 45 seconds to 90 seconds like maximum for the one question. So the calculations, it should happen, and then should get the diagnosis immediately. And for all this, the best is the life in the first lane, and also in the daily rounds in your ICU. If you do this and regularly, at least for the next 2 to 3 months, and this station is very easy for you. And I'll tell you, the part 2 exam, the most difficult like part is the CBS, if you ask me. So for me, it was like CBS was like most toughest. The clinical case scenarios, it is like in the real case scenarios, uh, and you might think it's happening in front of you, but here it's not like that. It's more like the seeing the video and correctly get the diagnosis and answer to the point. So this CBS, and you need to like practice a lot. So after this, after the ABG, and the next thing is the laboratory and parameters and which scenarios. These are the most common conditions, and what we have seen in the last like few years. The most common thing is like a DKA and HHS and the central and the diabetes insipidus and the mixed edema coma and the thyrotoxicosis. Mixed edema coma, it might come up with some and obese and the lady with a cold extremities, encephalopathy and all that. So the scenario itself, and it will give you half clue, and you should get the diagnosis. And thyrotoxicosis, and they'll give you some signs patient can have on the ECG of under sinus tachycardia or AF or VT. So you will get the diagnosis. And the Addison's and disease, and the long-standing and the disease or like a tuberculosis or any cancer. So then uh, comes up with a recent disease, and the most of the time here they'll ask you the diagnosis and the treatment part. The treatment part will be, it will take around half of the mark on the diagnosis. So if at all, if you're aware of these case scenarios, it will be like the most important and for you to approach it and very well. And the HUS, hemolytic uremic syndrome, the TTP and the DIC, all these three, if at all, if you have a peripheral smear in your like scenario, if you have the LDH or the creatinine or encephalopathy, fever, think about the TTP. If you have PT-INR and then fibrinogen or and LDH, it will go like more favor of in the DIC. So looking at the question scenario, and you should get half of the diagnosis there. And the apparent induced like thrombocytopenia, it comes up with like patient like post CABG had some, so started on the anticoagulation. After like 4 to 5 days, patient had a thrombocytopenia, or the patient on ECMO, and you see the ECMO circuit is getting in the clot, and you can see the clots in the filter. It can be hit. So all these are like a scenarios, the most common scenarios, and happening in all the ICUs. And if at all, if you know these like scenarios, if you know the disease well, the scenario, it can be tackled very well. And the rhabdomyolysis, they can give you like post-op patient or a trauma patient with the high CPK levels. So it is under rhabdomyolysis, and what will be the treatment and the hydration, all that. And the tumor lysis syndrome. So they'll give you like background of the CA underwent like a first cycle of the chemo or second cycle of chemo, has come up with in a shock, and they'll give you all the calcium levels, the potassium levels, the creatinine levels, all that. So it goes in like more favor of a tumor lysis syndrome, and the refeeding and the overfeeding syndrome. So this I've seen, and very commonly in my exam, I had a patient with the refeeding syndrome. So they'll give a scenario that the patient is not eating since like 15 days. He's a drug addict, and he has like a fell hill, and he was not seen by his like bystanders for like 2 weeks. And after that, he was like brought to the hospital and started on the feeds, and suddenly had a respiratory failure. So this goes in like more favor of it on the refeeding syndrome. And the toxidromes, so your approach for the toxidrome should be like specific. The most of the time it comes up with under paracetamol, like a poisoning, or any under antidepressants or any anti-epileptics and all that. And the toxic shock syndrome, so they'll give a history of the drug allergy or the consumption of any drugs. It goes in like a favor of the toxic shock syndrome. So these are the most important in the topics for the CBS, for the ABG and other and the lab, the parameters and the station. Please make a note and read about these topics as well. And images, I think, and the Tapas has told most of the things, and always and read the scenario in the images. So, like post central line, the patient had a hypoxia. It can be under pneumothorax, or if at all, if a patient had a trauma, you can see like free fluid. Yeah, it is abdomen and blunt injury abdomen and the solid organ and the injury, and follow the basic rules. If at all, if you're taking like CT abdomen, CT brain, CT chest, skin, soft tissue, bone, and the parenchyma sometimes, and they can ask you on the hardware devices in the images, like intercostal tubes, like pacemaker wires, or the IABP balloon and all that. So on the X-ray, I put only like a few things here. X-ray and the pneumothorax, it can be on the thin slide of the pneumothorax there. And Oglev syndrome, they'll give a scenario like on the post-op patient, or a patient has like a trauma, had electrolyte imbalances, and now has abdomen under distension and all this. So these are the patients which, though we see in our ICUs, and we may not give importance to it, but these are like and very important for the exam sake. And the hardware devices, they can ask you to name all the hardware and the devices. The most commonly, it will be the chest X-ray of a patient with a CABG or ECMO. And they will expect for you to tell the ECMO cannulas, intercostal tubes, the CABG and the staplers, and IABP balloons, and all that. And the CT scan, the brain, always read the question carefully. They might ask you that, please explain the abnormality. Please explain the abnormality. Please tell all the findings. If you get the diagnosis, and please tell that. If at all, if they and ask you, and you have like so and so image here, and what will be the next step? So, if you have a cerebral edema, how you and how do you approach the patient with a cerebral edema? So don't forget to mention the like features like midline shift and the location of abnormality, like and the right, left, temporal, the parietal, occipital, and features of the cerebral edema, like and the and differentiation of the white matter and gray matter, and the systems and effaced, the brain stem, this edema. All these things are like most important. So if and as and the Tapas told, and the earlier, and they had like a marks and the distribution, like and 5 marker and the 3 marker and one. So and now they've changed it as it's all one. So now, and whatever you tell is important. So, and if at all, if you get good marks, like full marks for any question, and the whatever you see, and you should speak out there. And the CT abdomen, pancreatitis, I had a patient with in the exam like pancreatitis, and they asked me to tell the CT severity index. So you might have seen the patients of like a pancreatitis in your ICU. Take those like CT scans, see in the system, open that, and see the like a CT severity index. How to see and peripancreatic and the fluid collection, amount of edema, the location, and all that is important. And Oglev syndrome, and as I told, and pyelonephritis. So keep seeing these images and repeatedly, so that your thought process in the exam, and as soon as you see the image, and you should get the diagnosis and tell the treatment. Yeah. And the ultrasound and echo videos are all like short videos, and they correlate with the scenario. The most of the time, so they'll tell the patient has the ARDS, and you have done the ultrasound, and so is like on the video. The patient can have like a dense consolidation, or there can be no on the lung slide as well. Even with the dense consolidation, the patient cannot have on the lung slides. And do this in your under daily practice. So if at all, if you are doing it in daily practice, it won't be actually difficult and for you in the exam. And they can give you the young lady, pregnant lady who underwent the delivery, and then following that, and she had hypoxia, the stress cardiomyopathy. They can put a like video of echo video of apical like ballooning. So if at all, if you know that, if you have seen these and the videos, like practiced it, yeah, then you can actually and answer in the exam. And the most of the time, patient with acute coronary syndrome, the complications and the ventricular septal rupture, aortic and the dissection, the pericardial and the tamponates. And for the pericardial and the tamponade, be aware of the different sign with the expiration, inspiration, what actually collapses, the atrial collapse, the ventricular and the dilatation and all that. So if at all, these are like hot topics and you should know for the CBS stations. And the trauma patients, most of the time it will be the pneumothorax or some like fractures and like free fluid in the abdomen and the vascular injuries and all that. And so now, so we have seen, I think in the last few years, the transcranial and the Doppler images are coming up for SAH to see for the ratio and also for like a brain that and the reversal of the diastolic and the systolic and the flow. So the transcranial and the Doppler as well, and the most important. So next, I think Tapas has already told on the arterial BP and waveforms and the over damping, under damping, and other abnormalities like and aortic and stenosis, aortic and regurgitation, and the low SVR, high SVR, and also higher BP. All defects are important in this early inflation, late inflation, deflation, all that is important. And it is being asked, if at all, if you know IABP and the arterial BP and the waveforms and very well, if it has come in the exam among the 8 to 10 MCQs for that station, if 2 or 3 waves have come, so if you know this and very well, it is like packed for you that like 3 MCQs have come for you. So please make sure and you know these like basic things and very well, and you know how to approach it and identify it and answer the treatment and how to solve the issue. And the ventilator and the graphics, here you should be in a very structured way. So always understand the like scalars and the loops for any graphics and the mode of the ventilation. So they might ask you on the mode of the ventilation and also abnormality. They'll put a scenario and then they'll tell, please tell which mode of the ventilation and what is the abnormality. So if you have understood like scalars and the loops, the constant flow, the pressure volume curves and all that, so then it will be good enough to see for the like a mode of ventilation and answer it, and also abnormality and auto PEEP and low compliance and the leaks like a bronchospasm, and how do you troubleshoot it. So this is also important because in these case scenarios, they'll ask you the troubleshooting them and how to change the ventilator settings. If at all, if there is an auto PEEP to keep for the low tidal volume, low respiratory rate, the low compliance, how to assess the compliance, and the bronchospasm, how do you treat it, and to start the bronchodilators and to keep on the low tidal volume or high tidal volume. Everything will be asked. And if at all, if you practice this in your and the daily ICU shift on the bedside and discuss with your and the colleagues and the seniors, it will be good enough. At least spend around half an hour to under 1 hour in your ICU on the bedside on all this. It will be sorted out for you for your exam. So always like make sure, if at all, if you don't understand, and you can ask your on the senior consultants or your like seniors, and keep your approach on the like a bedside so that you will not have the tension in the exam. So most of the time I have seen my own and the seniors or the juniors, so they must have like prepared and very well, but if they have not done an adequate amount of like practice just before the exam, so then they'll get tense, though they know answers, but they'll not able to detect the abnormality and answer it on time. And so this is all about the CVS. So now comes clinical case scenarios. I think I'll not go with this. I think under Tapas has already told 3 different minutes and the 30 minutes before Viva. Utilize, if they give you 30 minutes, it is good enough, and utilize 30 minutes effectively with each case. Get your under thought process for the real case scenarios. Think that, and you have this case in front of you, and how do you approach it, and summarize the case. Differential diagnosis approach should be with always with airway breathing and the circulation, and point out all the significant history in the scenario for summarizing the case. So the polytrauma, so give importance to answer injection like TT and the primary surveys and the adjuncts of the primary survey and the securing 2 large bore IV cannula, IV fluid under resuscitation. See, if they give you the vignette and they'll tell you like so many fractures and so many things, how do you manage? So you should start with the airway breathing circulation. I'll secure in the 2 large bore IV cannulas, take the samples for the basic investigations, for the grouping, matching, and all that. Start with IV fluids, and you will grade the hemorrhagic shock with and the vitals. And I mentioned the grade 1, 2, 3. Activate the like a massive transfusion protocol. I'll give injection under tranexamic acid. So they might ask you the evidence as well. You should be able to tell evidence for everything, and involve the trauma team, ER, anesthesia, ICU, general surgeon, plastic surgeon, neurosurgeon, and orthopedics. If you don't tell this, it is being like followed in all the multidisciplinary intensive care units, and you should like follow the same in the exam as well. So please be aware to involve other specialties as well in your like a case scenarios, and the management of the triad of the trauma induced coagulopathy. So this is all about the trauma. So then in the neuro cases, it can be the stroke, or it can be the cold cases like GBS, like myasthenia gravis as well. I had a patient with a GBS in my exam. So, and always involve the required under specialty. So with a surgeon or a physician, and the neuroprotective measures. So never and forget to mention the neuroprotective measures. You might have to tell in detail about the targets of the like PCO2, the PaO2 levels, like BP and all that, and any change in the GCS of any neuro case, and always ask for the CT scan or MRI. And any worsening in the general condition of the patient, always anticipate for any and hospital acquired sepsis or the complications of the primary problem. So like if you have the patient with a subarachnoid hemorrhage, patient can have the rebleeding, the hyponatremia, or hydrocephalus and vasospasm. If the patient had meningitis, if there is any the low GCS, it can be the status epilepticus, and the non-convulsive and the status epilepticus. Ask for MRI and the repeat LP, all that, and all this, and also on the requirement of the tracheostomy. So they might ask you evidence for the early and the late and the tracheostomy, and all these and the neuro cases. Like most of the time in the case scenarios, it will end up in the hospital acquired infection. So they might ask you like bundles, and which all the like preventive measures, and you will take in your intensive care unit to prevent in the hospital acquired infections like VAP bundles, CRBSI, like a COTI bundles, all that. And whenever you suspect any sepsis, and your answer should be, I'll start and the antibiotics, and as per the hospital or the ICU nosocomial epidemiology, with the gram negative cover and the gram positive cover, and if required, if the patient had any immunosuppression, with antifungal as well. Please mention this and vocalize it in the exam. It will give you marks. And all neuro cases, they'll end up with in critical illness, neuromyopathy. So then they will start with the prognostic evaluation involving the rehabilitation team, and they land up in the end of life care. So end of life care, I'll have a slide on that. We'll go in detail with that. So GIT, always under suspect the patients with a GI bleed. It can be under non-varicose or varicose. Start with under pantoprazole. Have a targets for the hemoglobin with evidence. They might ask you the evidence as well, and the plan for endoscopy within under 24 hours. If it is in the varicose with the background of the CLD and the terlipressin dose, endoscopy findings. I had a patient with like GIT, I think in the CCS. So on the antibiotics and importance of the antibiotics and to decrease the mortality in the CLD patients, and albumin, so to prevent HRS. And if at all, if they might change with a second the vignette, with in spite of all these and the measures intractable in the GI bleeding, it can be they might expect and the Sengstaken tube or the tips, and always expect on the coagulopathy and the DIC and the measures to be taken after on the massive transfusion. If at all, if you get the vignette with the patient is and the hypoxic and the requiring any the oxygen support or NIV got intubated, the differential diagnosis should be on the fluid overload like TRALI. And this GIT always look for the complications, SBP and HRS and hepatic encephalopathy. They might ask you for counseling for the liver transplantation. It's an emergency liver transplantation. So be thorough with all the scoring systems for the acute liver failure or acute on the chronic on the liver failure. How do you grade them? And the child book scoring system and MELD scoring system, all that. So other part, so which is the bread and butter for the intensive care and the pancreatitis and ERDS. You should know in detail about the pancreatitis flu, coming with the diagnosis, the management of the CIRS response and the IV fluids, the feeding and when to start, how to assess the response for the feeding, and the severity and the scoring systems, and the indications for antibiotics in the pancreatitis, and the interpretation of the CT scan. We should know about the CT severity index, look for the complications and management. And after the fluid and resuscitation, after like 4 to 5 days, they might change the scenario to abdomen compartment syndrome. How do you manage the abdominal compartment syndrome and also land up in the sepsis? So all the scenarios, it goes like this. And then if you take like a cardiovascular, patient might come up with a ACS and the cardiogenic shock. They might give you the ECG with like flat line and ACLS, and start with the CPR and the defibrillation and the out of hospital cardiac arrest. It might and change to like brain dead after like 48 hours. How do you do the counseling? And if the like a patient required IABP or ECMO, they can actually change the scenario to and procedure related and the limb ischemia like a bleeding, and look for the complications of the ACS and the heart failure and ventricular septal rupture, tamponades, and the valve regurgitation. So, see why I'm telling all this is, if at all, if you get a scenario in the CCS, if at all, if you know that okay, it is a GIT case, you should have a thought process of all the complications of that specific scenario. So if you know those complications, yeah, then you can actually think, okay, so my case scenario might go in this way. So if at all, if you have to answer in the exam, and you should know these complications in detail and how to diagnose and how to treat and manage them effectively. So, and respiratory, this is also like bread and butter. If at all, if you have the respiratory, and what my suggestion is, read this and very well. The most of the time, you will be lucky if you get in the respiratory, because you can pass very well in this station, because most of the time it will be cap like a scoring system and the antibiotics and the rationale. It is for the bacteria or and viral cover, or they might ask you for the COVID as well with the steroids. And ERDS, you should know everything about ERDS, the Berlin definition, the severity of the ERDS, and approach for hypoxic patient. Initially start with NIV and HFNC and evidence for everything, and they'll ask you evidence in respiratory cases. And after a few days, patient got intubated. It's like VAP. So now the ventilator and the non-ventilator under strategies. So they might ask you the evidence with the mortality benefit and the prone ventilation. You should know the physiology here and also the evidence. They might ask you percentage of the mortality benefit, because these are the landmark and trials, and you should know about this in detail. And after all this, ECMO, VV ECMO or the VA ECMO, the troubleshooting of the like, VV ECMO and the VA ECMO. And at the end, they might put the patient for like a poor prognosis and for a discussion for end of life care. So next, and the obstetrics is very easy, and you should be aware of the physiological and the changes in the pregnancy You should know how to diagnose like preeclampsia, eclampsia, the PPH. If you get a case with like a PPH, involvement of intervention and the radiology for embolization is like very important. And they please and vocalize that you will involve and obstetrician as well in the massive transfusion protocol and also DIC management. And the second thing is the most commonly asked is the peripartum cardiomyopathy, and the definition, the management, and the counseling the patient for the future and the pregnancies. It was asked, and for my junior batch. So the patient had like a peripartum cardiomyopathy. How do you counsel the patient husband and the patient for the future pregnancies? It all depends how they have recovered, how much was the LV function. So, and you should know in detail about this. And the end of life care discussion, if you have like a 3 case scenarios in that, like the one patient like will have end of life care discussion for sure, and the other can have the brain death. So they'll and you will have under 3 examiners, and they might change and they might tell that under 2 of the examiners can be the patient and the family next of kin. So in that, and they might ask you, how do you initiate end of life care and the policy or the discussion in your hospital for this patient? So always like start with introduce and yourself and speak with empathy, the compassion, understand them and what I exactly want, and stress upon the age of the patient, the background illness, and the quality of the life, dependency for the daily living, if at all, and ask them if the patient and has any the will written for him, and tell about and the prognosis of the disease in detail, and the benefits and the risk of the treatment to be continued, how it will be. And always and read about European end of life care guidelines and like brain death guidelines as well. So there are under slight variations, but it is important. So the last slide now. So things to and watch for this EDIC part 2 preparation is that teach each other, like practice with a friend. So remember 90% rule. If at all, if you do the discussion with your seniors or colleagues, it will be best and for you to remember in the exam. And also your approach will be good. Develop good habits to discuss, and from hard work it is always and the smart work for the like a part 2. The create like pictures, draw diagrams, mind maps, the turn the abstract on the theory into the actions and the images, and always mental gym. It is mental gym is mainly for ABGs, and to approach the ABG for the triple disorders, for the double disorders, all that. Avoid cramming. Avoid cramming in the sense, don't do intense amount of preparation for the last like in the few days of the exam. It will actually make you under stressed out. Start the preparation at least around 3 months before the exam, and avoid multitasking. If you have taken any topic, okay, go in detail about that, address all the complications and the treatment, and eliminate the student syndrome, and you are not under student anymore. They are going to assess and whether you're going to become a consultant and you're competent enough to become a consultant or not. So thank you.
Yeah. Thank you, Dr. Manjunath, for your excellent deliberation. And I know you have touched upon most important things what the candidate normally forgets. And definitely they would vouch for the most important things what you have already mentioned. So any questions by the candidates or the delegates or the aspirants,
I
the
think
friends,
in
the
the chat
colleagues?
box, I think Len, a
Yeah,
few questions are
there
there.
are
I'll
certain
just
questions. I have answered few of them. And
okay.
what is the best OSCE book? It's difficult to tell, but yes, there are 3-4 OSCE books normally by like the UK. Well, there is one on the objective structure, the exam preparatory course. I have already shared in the my slide, and Australian board there are 2. So you can choose all these like no 2-3 books, but yes, you have to go ahead with like no the important like no the clinical cases normally that can be asked from each domain. So you can make your own like from gastroenterology, just like as Dr. Manjunath has told, there would be only 5 to 6 important clinical case scenarios that can be asked. But yes, the problem with EDIC part 2, they would not restrict only to the pancreatitis or like no the abdominal compartment syndrome. So they would definitely move ahead with the like no the clinical case scenario would end up with like no the kidney problem next day, then the third day would be a multi-organ failure, then fourth day would be some complication in the ICU, like no the tube the patient has taken out and now the patient is right now cardiac arrested and you have started with resuscitation. So you cannot like no make it a single domain. So that's the problem with EDIC part 2. So that's the reason why we want to highlight again and again, you have to have a like no a holistic approach to critical care. But yes, you can make most important domains of each system and like no start reading the most important questions, the landmark trials, the management protocol, and the important the CBS questions that can be asked. So because it would be one in go. So if it is like the clinical case scenario, then you have to also read about the CBS. And this is our format for in the last. And as we discussed, we would be starting with the different clinical domains like cardiology and cardiothoracic surgery. Very important. If in the Cobatris, like no the schedule, if you can go through, it almost carries 20% of marks in the part 1. So also part 2, it would carry like a similar percentage. Trauma and toxicology, sepsis and antimicrobials, neurology and neurosurgery, respiratory system, oncology, pregnancy, burn, drowning, like no hypothermia, hyperthermia, nephrology, endocrinology, gastroenterology, ethics, organ donation, communication, very important domain. At the end of each clinical vignette, you will be like no expected to answer these things like no the communication, organ donation, ethics, and hemodynamic monitoring and the different miscellaneous questions at the end. And you would be getting 2 clinical case scenarios in each domain, and there would be also almost 15 to 20 or 25 CBS questions related to the cardiology, cardiac surgery, trauma toxicology. So you are actually getting, yeah, if I would say there are 10 domains, almost 20 clinical case scenarios you would be like no getting before your real mock test, because at the end of all these 10 domains would be going ahead with the mock 1, mock 2, mock 3. You can see here in this like no module details. And there are like no the faculties from international arena like Dr. K.R. Ramanathan, just for the example, he's from Singapore, and you can see, you know, most of the people know he's expert in cardiac surgery and ECMO. So like Dr. Pramod Guru, he's from Mayo Clinic, Dr. Nasa from Dubai. So these are the people who would be like no giving you certain like no tips and tricks from their own experience. Dr. Sumitre, one of the famous, like you can say, renowned sepsis specialist, you can say. And this is the like no module details date wise. So every Saturday there would be exam, and Sunday there would be debriefing session. So and that will be again like no you would get the recorded versions. So with this background, I would expect like you should all be ready to like no at least apply this EDIC part 2, because you have to first get the seat in the upcoming season. Then only you will be like no start preparing. But if you have any problem related to like no the applying the part 2 exam this season, please contact me or any of our like no colleagues, and we would be definitely helping you. And in case you are the interested in our part 2 tricks preparatory course, definitely this course is open now. You can register. Yeah. Thank you all of you. And thank you for sparing your valuable time in the weekend. Thank you, Dr. Manjunath. Yeah, Dr. Prasanna. Yeah, please tell me.
Yes, sir. Just during session, you mentioned that there will be opening of link for registration on 9th for some of the students. So
Yes.
I didn't understand it, sir.
So actually, no, there are many candidates. Last time they tried but could not get a seat. So ESICM has actually taken it seriously, because that was the fault from their side, because the site was somehow like no collapsed, or you can say somehow there was a problem. So they paid the money, but somehow they could not get a seat, and the money was refunded. So the ESICM has taken it seriously, and they just held certain seats for these candidates who have applied last time. So for them, they individually sent the emails for one early date, you can say.
Oh, okay, sir. Yeah, thank you.
Thank you
And
so much,
have
and all
written
of
about
you,
when the deep yeah.
and
Yeah,
all the
Charlie,
best
yeah.
and for your exam. Any question? Yeah.
So do you conduct tricks for EDIC part 1? Yes, it has
Yes,
already
yes.
started. So you can contact me, and I would be sharing all the details, because it's already started. Because part 1 is just 1 month before the part 2. So there are only 3 months. And opening registration, I think I have clarified that. Debrief session is individual, live, or common recorded. The problem is we are almost having 40-50 candidates. So each week getting time from the candidates is also very difficult, because you would be also busy with your the hospital assignments, the duties, and your family things. So people, they cannot give you the time slots also. So for that reason, it would be combined each week. But at the end, when we would be going ahead with the mock test, so it would be 1-to-1. So we would be getting your slots, your preferred slots, and we would be assigning you with one of the the esteemed faculty, and they would be taking your exam 1-to-1, and it would be just exam related. It would be all they would be having one iPad or laptop, and they would be marking you. At the end, you would get the exact marks that you have scored. So my number I am just sharing here. Dr. Manjunath is also there. Dr. Manjunath is one of the esteemed faculty, very young, dynamic, intensivist. So he would be also helping you to crack your exams. We have also Dr. Sananta Kumar Das. He is the also course co-director. He's from Australia, but somehow he's traveling now to India, so he could not be part of it. But the next session, the pre-introductory class would be also attended by him, and he would be sharing the details with you also. So I am also sharing Dr. Manjunath's number here. So you can all contact. Yeah. So already he has said. So we hope that this session was very useful, though it was a little bit exhaustive, but we didn't want to miss any of the things. Though maybe you would find that it is all repetition of what you know, but we expect that this would be one eye opener, and most of the things would be cleared. Sorry, I have missed 1-3. Yeah. It's all 3-3-4-3.
Sir, can I ask
Okay.
one question?
Yeah, Dr. Ruchi.
Yes, sir. Actually, I have a doubt. I have to appear in my IDCCM exams. So it's on March 10th, and the Viva will be in April. So is it wise to fill up the form now, part 2? Like,
So,
No, if you ask me, so
will
this
it
is like,
interfere?
no. So it won't interfere and with your exam. So, but if you ask me, see, you have done the theory and you have given like a part 1 the cleared. So it will be the best time and for you to apply for now and finish it off.
Okay,
Again,
sir.
doing for the part 2 separate preparation and all that, it will be difficult. So please go ahead and fill the form.
Sure, sir. Thank you.
So can I ask a question?
yeah,
Yes,
please.
please.
So I mean, you did share the tricks to preparation stuff. I just wanted a bit more clarity as to how you're gonna cover because last time as well I appeared, I cleared the clinical scenario, but I wasn't able to clear the CBS stations. So I mean, how are you gonna cover the CBS based stations? Can you just highlight a bit on that?
Yes. So the idea is I will give you example for module 1. So cardiology and cardiothoracic surgery. So there would be 2 CCS the case scenarios, one related to cardiology, one related to cardiac surgery, like that. And after that, there would be almost 20 questions from the CBS. And the CBS would again from the cardiology and cardiothoracic. That would be ECG, that would be TAKE, that would be something related to some hemodynamic monitoring, something like that. So each domain would be 20 questions. If it is trauma and toxicology, so there would be some the toxidrome clinical scenario, and there would be some hospital gap or something question related to that. Sepsis, antimicrobial, some culture sensitive report, some CLAPSI, equation, something like that. Neurology, it would be ICP waveform, then some like TCD waveform, something like that. Respiratory, ventilatory graphics. So like the system specific CBS, the three CBS what we have already discussed, the graphs and curves, then ABG, like your data interpretation. So every domain would be involving almost 10 to 15 from the respective three stations. So at the end, you would be getting almost, I would say, 150 to 200 CBS questions for practice. And then at the end, there would be again 3 mock tests that would be having random all those CBS questions. So you are getting 200 to 250 CBS questions to answer. So I hope that would be and after that also exam, you would be referring those things to clarify your concepts. So that would again give you almost 100 to 250 questions if it would be little bit changed in the real exam, and you can easily answer that.
Thank you, sir.
Because online exams, apart from this and above this, we cannot provide more details, because it would be believe me, these discussions would last for almost 2.5 hours to 3 hours. So sometimes the candidates also feel little bit exhausted. So if you will start at 7 o'clock, this sometimes the classes end up at 10 o'clock. So 2 clinical case scenario, almost 20 CBS questions, which are almost exhaustive also. So each part will be almost 2.5 hours to 3 hours. And every Sunday, imagine there would be 10 Sundays you would be sparing for you this these classes, the debriefs. So it's not so easy. And you have to again prepare for the trauma and toxicology just after 1 day. Monday you would be getting the articles, important articles related to trauma and toxicology, and the clock starts from there itself, because you have only 11th night you would be having debriefing. From 12th you would be starting preparation from trauma and toxicology, and on 17th you have exam for trauma and toxicology, and 18th you have again debrief. Then next week, because otherwise you cannot finish the whole critical care. If I would be spending 1 month time in cardiology, cardiothoracic surgery, maybe I would be little bit more confident, but this is not going to help you, because you have to be thorough almost in 70 to 80% of all those critical care curriculum. Then only you will be confident in answering those questions. Right?
Got it, sir. Thank you, sir. Thank you.
Yeah. Dr. Manjunath, anything from your side related to this one?
Nothing. I think so. If at all, if they're aware of all this,
Yes.
whatever points we have told, it will be good enough, and for them to do the preparation. Believe me, when we were giving exams, nobody has told us all this. So, and you have
Dr. Manjunath, you must be remembering, you called me up how to prepare, how to go
exactly.
ahead with this CBS or something like
Yeah,
that.
exactly.
So that was the story at that time.
2017, 18.
Yes.
Yeah.
Okay. Okay, guys, don't worry at all. Everybody feels same thing when they start preparing. We have all gone through the similar phase. It's not that we are we may be other side of the table right now sitting, but yeah, the preparation starts like that only, and most of the people they clear if they follow some basic principles as highlighted by me as well as Dr. Manjunath. Keep calm and start preparing. Don't waste time only thinking about that. Yes, I have to do something. I have to do something. Okay. If you
Sure.
feel, then you can also join the next introductory class on the date what we have mentioned on 18th. Okay. Okay. Thank you all of you. Have a great weekend.